Welcome everyone to the Hey everyone, welcome everyone to the ASCS and Precision OS collaboration here. Very excited to welcome everyone. I'm Grant Garrigues, the head of the ASCS VR task force. We also have with us tonight Jay Levin, current fellow at Rothman Institute, shoulder and elbow program, and Chris Clifto, shoulder and upper limb guru at Duke University. We have the Danny Goal and the entire Precision OS team has been working in front of the scenes and behind the scenes and can help us pull this off. Danny is obviously the CEO and founder of Precision OS VR that we've worked with as part of the ASCS. And then last, but certainly not least, we have JP Warner. We're very honored to have him here as our first VR professor. So Dr. Warner is the co-chief of the shoulder service at Mass General, professor of orthopedics at Harvard Med School, and the founder of the Boston Shoulder Institute, and also someone who has a lot of experience, interest, and expertise in the VR environment. So very excited to have everyone here tonight. And without further ado, we'll get started.
Great. I'm going to just share my screen. Thanks for that introduction. The nice thing is when you're a VR professor, you don't have to travel. So I'm doing this from home. Give me a minute to just can everybody see my screen here? Let me just put it on presentation. Give me 1 minute. Here we go. Okay. So what I'm going to talk about here is really a paradigm shift in education. And we'll talk a little bit about what that means in a moment. I have some conflicts of interest which are disclosed to the Academy, and specifically here with Precision OS. I'm not going to talk about other specific products. So a paradigm shift is something that is kind of the basis for non-derivative innovations in business. And, one of the interesting things in innovation is it can be too early, too late. Timing is everything. So I think some context is appropriate here. And if I would tell you, I'm of a different generation, and I went to medical school before Google. Really wasn't the digital age at that time. And 1 sec, I was a baby boomer. Now, in addition to that, if you look at the current gaming industry, which is an indication of how digital we become, you can see the significant growth over time. And many of you watching here, or those who may watch this recording, maybe Generation Y, Z, or even Alpha, and you can see the difference here in the mindset of these folks. Many are now digital natives. So adopting this is very, very easy. So I want to ask you to think about orthopedic care, shoulder, or whatever, as a digital episode of care, and where digital technology will fit from the standpoint of the value it can create. And if we do that, then the episode really begins with education, because it's through surgical simulation and decision-making that we can practice on demand and in the metaverse, if you will, with experts, that makes it very easy to learn skill sets. So which digital technology will have the greatest impact? There's a virtual alphabet between VR, MR, AR, etc. And so what is the difference between these different modalities? So let me just briefly explain this. So if you look here, mixed reality are virtual objects anchored in the real world that allow for interaction with digital images in real time. Augmented reality is just superimposed digital technology in the real world, and you can see here venipuncture in the center. And then virtual reality is a computer-generated simulation where you enter a virtual world where there's an artificial environment that allows for interaction anywhere, anytime, with anyone, already used in many other spaces, and it doesn't require a laptop, it doesn't require wires, and it's relatively low cost. And so these are examples of what MR looks like, and of course, what VR looks like. And there are a number of videos already out in ViewMany and other sites that talk about the difference between these things, and I invite you to take a look at that so you understand what we're really talking about here. Now, I was asked at one point to talk about gaming, which is a $219 billion industry, and my brother is in the gaming industry. And VR gaming revenue using VR was only about $3 billion in 2024. And the reason for this is just the mindset of folks that are using it. They're not using it for immersive education the way we're talking about. So we have to differentiate from that. I'll get to the details in a moment. So if you look at golfers, they're learning muscle coordination and steps, which we learn in the operating room, and they get feedback about how well they're doing. So why couldn't we do this in the virtual world? And it's already being done, of course, in flight simulators. And the answer is clearly that pilots are better at what they do by simulating flights and, most importantly, the errors to avoid, which we can do as well. So if we look back, it was William Mayo who said there's no excuse today for the surgeon to learn on the patient, and Halsted said see one, do one, teach one. But that doesn't always work so well, and the learning curve is really problematic. And this is just a list of some of the problems. The way we educate now is relatively expensive and time intensive with cadavers and access to specific cases, slower learning curves with a penalty for the value that you're trying to create for your patient. There are no clear metrics for improvement skill. It's not directly related to the patient. And there's limited experience available for residents and fellows in the course of their education because of other demands. And so all of these different methods that we use that are mainly in the real world are kind of surrogates that don't really replicate what we want to learn in order to avoid problems in patients and to do our operations better. And so current education is a problem now because Moore's law basically describes acceleration of technology and processing speed. We're now at a point where immersive VR is possible. And that's why we're bringing this to you now. What about evidence outside of orthopedics? Well, we can draw some extrapolation to the gaming industry because it's clearly been shown that those that do video games are much better at doing arthroscopy. And in a study here, 575 participants in 16 studies using laparoscopic training and robotics, and individuals who did video games demonstrated significantly better surgical skills. So if we look at the evolution of virtual reality in shoulder and elbow surgery, there are a number of clear advantages. It's realistic, it's inexpensive, it allows motion analysis, it allows for haptic and sound feedback, and that's improving all the time, as you'll see in some of the videos I'll show. You can monitor efficiency, you can practice errors in order to avoid them, you can score the progress, and you allow for remote interaction, which is probably one of the most exciting things ever, and you'll see how that works. So this enhanced learning journey, if you look at the graph on the right, proficiency is up, complications are down, and in the traditional learning approach, there's a long learning curve during which errors can be made that are problematic for the patient. But if you practice with VR in advance, you shorten that learning curve and you get to a much higher level of proficiency faster. And I'm not just saying that, there's plenty of evidence for this. So if we look at some of the applications here and how it can work, you can do all sorts of things. You can simulate errors like you're seeing here with a wrong cut. You can then make the correct cut and be accurate in what you're doing. You can do this with arthroscopy, not just in the shoulder, but in other joints as well. And you can simulate exactly what the scope does, and we'll do that in the virtual OR together when we jump into that next. You can do collaborative learning with individuals from anywhere in the same space with you, and the social interaction is quite palpable and realistic. And you can have a conversation and use the VR surgery as a way to interact with the anatomy and the pathology and discuss how each of us might do something slightly different than the other one, but using steps that are simulated in order to be the basis for that interaction. That's much more tangible than if you were just watching a video and talking about it. And so there's a lot of articles and research here. I'll share a little bit of it at the end if there's time, but just so that you're aware. If you look here, you can see even basic anatomy is possible. So we can take the body apart in layers. We can look at neurovascular structures, muscular structures, bony structures in a variety of ways. We can walk around the individual, the simulated individual here, and we can also subtract and add layers while we work, which gives insight into where are the nerves and the blood vessels running, etc. And we can even simulate surgeries, as we'll see in a moment, where you can draw where your incision is going to be and have a conversation about it. You can then remove parts of the muscles of the shoulder so to see what's underneath it. Where, for example, is the axillary nerve when you do an exposure? How about when you place your arthroscope? What is the proximity of the axillary nerve and other nerves and this sort of thing? And here you can see how we can draw and even introduce the needles and arthroscopes, etc., which again, you're going to see in a minute. What's interesting as
Standing.
well, and I'll let
talk
Danny
to
do
you a
the
little bit
talking
about
here. I
how
hope you can all hear
set
it.
up my OR when I'm doing a shoulder arthroscopy. And I'll talk a little bit about arthroplasty at a later session. Now, when I set up a patient, usually they're in beach chair. As you can see here, I try to make the drapes go as medially as possible. And I like to set up the scapula along the medial scapular border, which is on the edge of the table. And if I show the anatomy here by turning the anatomy off, you can see the medial scapular border is here. What that allows me to do is have free mobility of the arm, because I want to be able to not only extend the arm, but also adduct it. And that obviously pays dividends when I go and do an arthroplasty. But in this first experience, I just want to showcase how I approach a anterior rotator cuff tear, which you can see here. Now, when I use my arthroscopy setup, if I grab my camera and I have the arm in port elevation, you can see that if I'm looking from this posterior superior portal, that I get not a very good view, or a little bit of a challenging view of the anterior rotator cuff. So what I typically do is I'll extend the arm and actually rotate it. And if I use that scope from that same portal, you can see here, I get a much better view of the anterior footprint. You can see here. So more on this later, but I think talking about how to contextualize the arm position with the camera and the scope relative to the portal gives me the best view of the anterior footprint of the rotator cuff. And you can see the biceps tendon right here as well as a good landmark. Turning this off, you can see the view that I get when I have the arm extended and X-ray rotated versus if the arm is flexed forward, I can tend to lose that view pretty quickly. So that's the first iteration on how to do an arthroscopic rotator cuff repair. Thank you.
So another demonstration here. And this is from the orthodome presentation that's been shortened a bit that Danny did at the Academy, which I think shows you how you can take the simulation and make it very realistic, because side by side, we're going to show you what we actually do, simulating the surgery, and then actually doing the surgery. So each of these steps is carefully constructed, not only to allow you to make the operation, but to make errors along the way and be informed that you made an error, as you'll see in a moment when we do interactive surgery together. And so you can sort of see here the different steps. I'll kind of cut this off because we're going to see some more in a minute. But this is the concept of how we approach this. And of course, we'll be talking about arthroscopy. So what if surgeons could work together in the same space without traveling? So here's Danny, myself, George Athwal, and Joaquin. And let's see how this works.
Got Damon, Clooney, and Pitt in the OR with me. They can decide who they are amongst themselves. But the whole goal is to showcase how George is in London, JP's in Boston, and of course, Joaquin's in Rochester, and they're all in the virtual space together.
We can take the humerus out and rotate it in space, look at it from different angles, which will really help when we're actually doing the procedure if we want to.
That's for your entry point. So one nice feature of the VR space, as you guys can see, is that I can point to Dr. Warner and tell him, where are you making his entry point? That's important. We can collaborate. I can actually take the guide out myself if I wanted to, or move it. This is now Joaquin's hand. I'm gonna take it out, and now probably George can do the same thing and manipulate the guide.
It's not too bad.
So if you look here at it, what do you think now, George, in terms of the cut height?
Looks like I did take off a little bit of the lesser, but it's not too bad.
Fine. So let's go ahead and do the reaming. Standard the reaming, the reaming with a 3 here. And I can feel the vibration, and then before we stop there, now we're done. We'll put this away. So let me take this out and address that, Danny. So if you look here, this is what you're talking about right here. Can you all see that?
Yeah.
Okay. So you see the interaction. Here's an example of even a broader interaction where if we zoom out, we have Vancouver connected to Boston, then we're connected to Ireland, then we're connected to Switzerland. And so
Today I'm joined in the operating room by my colleagues and from all different countries. So we have Florian and Carl from Switzerland and Ruth Delaney from Ireland. And then we've got Danny and John from Canada, from the western part of Canada, Vancouver. And then, of course, I'm in Boston. And we're all together in a virtual operating room. So on, we have an intramedullary guide. Can you see that, John? You're
Yeah, I
muted, yeah.
can say that. Yeah.
Okay, good. So 135-degree angle, and the saw's in my left hand. So the green line you see here is aligned with where we want it to go down the humeral shaft. And I can simply adjust version as I see fit with this. And so once this is set here and we have the same retractors that you talked about, Florian, then and now I can make the touch.
May I ask how much retroversion you are aiming for?
Yeah, the retroversion, I personally choose whatever is the retroversion of the patient. It actually usually winds up being between. So Ruth is now going to be the operator here. And you want to get the sizer with your other hand, Ruth, first.
Okay,
There we go.
so the next step of the procedure, we're happy with our cut. We need to figure out the size. And here we can tell this is going to be too small. We can cycle up through these sizes. And in this particular implant, we don't really want to be right up against the cortex of the metaphysis. So I would probably go with a 3 here. And so if I do something like this, I learn from error because, you know, I'll see whether this is actually somewhere that I want to put the implant or not. And the program is telling me guide pin is too shallow and unstable. So I haven't put it in far enough, as well as maybe not putting it in a good position. So it's telling me to start again. So I can redo this step. So I can put the in, and then same thing, we're going to cycle through the sizes. I think that a 3 is probably what I would choose for this. And then I'll see if I aim for more where I might like to put my implant in real life. And then it's telling me, like in real life, you should engage the reamer before you hit the bone surface. And then I can let it breathe down. And then there's a hard stop. And then the system will tell me when I've hit that hard stop. So I've prepared.
Maybe Florian can do the next step. Florian?
Yeah,
And then,
okay, so I can.
Rotate it where you want and
Where I want
lock the
it.
trigger. And then go
What?
ahead and insert the awl. And then go ahead and put that into the humeral canal. And as you can see, you can align it relevant to version and your
Yeah,
humeral cut. Okay,
Okay.
Don, can you
and
see that
now
well?
you-
Okay,
I-
good.
Yeah,
So go ahead and just bang with a hammer.
right, that's good.
Keep going.
Oh, and I get it. Yeah, there you go.
Now, one of the things that's interesting, Florian, stop right there before you take it out. Grab the inserter
Right.
handle by pulling on the trigger with your right hand to detach. So take your right hand and there you go. And now you take it out. So far, do you guys think that this is pretty engaging?
Very engaging.
So we've done this now in multiple places. I did it in Saudi Arabia, and then I went there and actually did the actual surgery with the surgeon that I did the virtual surgery with before I went there. And so just a few comments to finish up with. With residents, it's not enough OR time, not enough experience, basically. And so this has been created with the input of residents, as well as with a surgical education committee to weigh in on what we're doing and how we should replicate this. Here's an example of a bunch of surgeons practicing in a space, learning how to use this device. There's a number of studies that have documented how effective this is in terms of learning more in less time, being more cost effective, and increasing surgical autonomy. In this instance, how it's superior to just reading, or how it's superior to watching a video in terms of the learning time, the surgical errors that you can learn how to avoid, and the cost per simulation. And as well, you can look here compared to benchtop training, some of the devices I showed you before, it's clearly superior. And, you know, looking at high volume and low volume surgeons and looking at the potential to make low volume surgeons as skilled as high volume surgeons quicker. Lots of additional studies like this looking at cadaver learning, which clearly demonstrated that this is equivalent to cadaver learning with significantly less cost, but no difference in outcomes. So, you know, questions already that we've answered. It's available anytime. It covers all specialties. It's relevant with abnormal scenarios. You know, your imagination can help you create whatever you want to study. You can track and measure the errors you make and your skills. It's just a question of programming it. And it's clearly there's evidence that increases the OR skill set. So that's my talk. I think the group has gone into the metaverse. Am I right?
Absolutely. That was great. Thank you, JP. Yeah, so time to don your headsets and dive into the metaverse. While you're doing that, I want to let all the participants know. Please prepare your questions for Dr. Warner and Jay and Levin and Chris Clifto, and put them in the chat at the bottom of the Zoom, and I'll field them their way. They'll be immersed in that environment, so we'll have to let them know there's a real world out here and have them answer some of those questions as they come up. I also want to make an announcement while they're getting in the metaverse that hopefully you're all planning to attend the ASCS annual meeting this coming week in San Antonio. So Thursday at 2 p.m., we will have our second installment. The professor will be Joaquin Sanchez Sotelo. We'll do a different module, and we'll have the Precision OS team will be there with headsets. So if you have your headset, you could certainly bring it, and they can help you set it up with the modules. If you don't, we'll have some there. And so you can try this out a real world in a very hands-on way. So Thursday at 2 p.m., it's in the program. I would love to see some there. And Jay, do you have a question? Again, I want to thank Jay Levin and Chris Clifto for all their work really on this. This is going to be an entire year-long curriculum. So we're just getting cranked up here. And like I said, we're excited to kick it off with Dr. Warner. Looks like we've got some questions already in the chat. So that's for the panelists. Perfect. Good. Well, again, if anybody viewing at home has any questions, please fire it away. We're gonna have Mike Brock from Precision OS is going to be basically in there with essentially videoing. So what he sees through his headset will be visible to all. Now, obviously, each participant is seeing something different that's specific to where they are and how they're moving through the environment. So we're going to kind of pipe out what he's seeing to everyone else, so that if you don't have a headset, you'll be able to experience at least some of what they're seeing. Obviously, the nice thing about the virtual environment is you can interact with it, and for that, you're going to need a VR headset.
So, Ryan, I'm going to need the login information to join everybody.
The
Right.
code is 8709, Dr. Warner.
Thank you. Great.
Perfect. Well, while you're working on that, again, and I should say too, a lot of work with different committees from the ASCS. So obviously Precision OS has been a great partner, and then the technology committee that Dr. Clifto heads has been valuable. The VR task force that I had has really come up with a lot of the modules and some direction from our side to the Precision team about what to develop, and they've done a great job working on those things. So in the chat, if you want to look at that, Danny just put a link that you can stream there. Danny, will that be the same as what we're seeing on the screen share, or is that something different?
I can answer that. That's the same.
Perfect. And I think hopefully everybody can. We're seeing that.
Here?
What's that, Dr. Warner?
You see us in here, all of us together? Gang? Yes?
Yes, we do. It's a little choppy for me. I'm not sure if anyone else has seen that, but we can see you in the environment.
Okay. So I'm joined with Danny's right. If you can see me here, I'm pointing at Danny. Jay is here. Chris is here. And Mike is here. Okay. And I'm standing next to this model here, which, we can grab and move and do as we wish. There are some things that we can go over in terms of the steps for doing this, but what do you think? Should we jump into the one of the modules? Are we going to do left or right? Who wants left? Who wants right?
Let's do it right.
Do a right one? Okay. So here, so I can select this case here.
JP, before you do that, just a public service announcement.
Yeah.
Danny recommended definitely use the viewer link. Some of the choppiness is because it's video over Zoom, so it's like double video. So if you use that link, it's absolutely smooth. So, obviously we'll have the audio through the Zoom, but please consider clicking on that link in the chat. Please continue.
Okay, I'll jump in the OR.
You want to start us here? All right, great. All right, we'll come into the OR in a minute. Here we are. So here's everybody here. Now, we're set up, and anybody of you guys who want to chime in, feel free to chime in. And I got to walk through here a little bit, but basically, here's our arm set up, right shoulder. We've got our table here with all different devices we can use. Arthroscope, you just squeeze the trigger to pick it up. Here's a probe, okay. Here's a marking pen. Here's a laser pointer, etc. And a whole bunch of other things, and including a needle even, okay. And so as we do this, we can actually grab and move the arm where we want to move it and place it around and such. Then you want to do this, I got to change my position here in the room. There we go. Oh, that's better. Here we go. So you guys can see that I can move the arm into flexion. I can move it down. I can rotate it. And I think most importantly, someone else grab it. I'm going to get out of the way and try to use it because anybody can move the arm.
Yeah.
So we can
Yeah,
share.
Dr. Warner, what's your preferred position for introducing the arthroscope? Like, how do you position the arm?
Usually for me, I'll bring the arm a little bit down, with a bit of traction with the arm holder, and about neutral like that. I won't really have it externally rotated that much. Although one comment I will make that sometimes the fellows don't understand: if you're doing a arthroscopy, you want to see the posterior labrum, or you want to be able to withdraw the arthroscope. Then if you externally rotate the arm, the posterior capsule becomes more lax, and it's easier to see the entirety of the glenoid. If the arm's internally rotated, it's a problem. But I'll usually use this positioning. Anybody else want to make a comment before we move forward? Everything okay? Everybody can hear me okay?
Loud and
Yes?
clear.
Okay. So we talk about portals. And so here you can see the coracoid, the acromion. And so if we look at where we might want to put the portal, if I'm putting it in for a subacromial approach or rotator cuff repair, then I can mark the portal here a little bit higher, might be lower for a instability. The lateral portal would be over here. I'll usually use an accessory posterolateral and anterolateral portal like that. And sometimes I'll even use a more anterior-superior portal like this. Now, that's everybody's different in what they want to do, but these are the principal ones here, here, and here. And then these are accessory for what I want to do depending on what I'm looking at, like if I'm doing a rotator cuff repair. And I think Danny helped me with, or somebody helped me with, I think we can make this transparent, right? So yeah, here we go. So if we do that, yep, great. So you can now see, or I'm looking at the muscles and such, and I can move the arm and see what that does. And let's go down to the can we go down lower than that with us here? Here we go. So now you can actually see the joint right here, right? And consequently, if I move the arm, you can see where structures you might not want to get involved with are located, and how the capsule might move. And so Danny put the arm in extension before. I can bring it forward. And if we put back the skin, we'll go here and put back the skin. Here we are back here now. So it's kind of nice to be able to see how am I planning relative to the layers. And what I generally do with arthroscopy is the scope goes towards the coracoid process. And to be fair, if you look at the soft spot right here, that's about equivalent to where the joint line is. And actually, I did a study a long time ago that if you measure the posterior lateral of the acromion, posterior corner of the acromion, and go this way 5.4 centimeters, you're about where the suprascapular nerve is at the base of the spine of the scapula. So these are just kind of external landmarks that you can then transparently look at and see what you're doing there. Okay. So anybody else want to make a comment here while we're at this step? Input? This is a team approach. Anybody?
Yeah,
No?
questions about, obviously we're in tune to the axillary nerve throughout all of shoulder surgery, I would think. For a 7 o'clock portal, how low are you comfortable going? Because it seems like the lower the better approach, but just curious your thoughts on safe portal placement for that portal.
Let's see. Let me see if we can do this. Let me get this off. There we go. And then we want to kind of see this. How do we get my muscles out of it? Okay. So, you know, the 7 o'clock portal is Basem loves to do that, my partner, because he does a quadrilateral space release. So what he'll do is he'll look with the scope this way and he'll do the release. He'll put a switching stick down here and then do a release of the quadrilateral space posteriorly. I'm not doing a lot of that. And to be fair, it's not really an issue. I don't think it's very difficult. You can get very, very low without worrying about the axillary nerve in the quadrilateral space, because look how low it is here and where it goes here, okay? And suprascapular is way over here. So if you're going to get the suprascapular nerve trying to go in the joint, you got to be like that, which is kind of a nice thing to see. Furthermore, if you look here, here's the, I don't know if we can see that, but this is the suprascapular notch. And I don't know if those of you who do suprascapular nerve release, but you can kind of see where that is and how we would look at it, because we'd be looking this way and instrumenting that way. And that's not the point here to show you, but you can sort of see the different structures here very nicely, inclusive of, if we rotate this way, we can see the axillary artery here and vein and the axillary nerve in the front. And my experiences with open surgery, most injuries that happen more distally, not proximally. Just sort of saying, if you take a look and see where that is. And we're doing an arthroscopy here. You got to work pretty hard to put the scope in a place where you're going to damage one of these things. You're really way offline. With open surgery, maybe not so much. Okay. Does that help with the question?
Definitely, thank you.
Let me fiddle with this. Let me first of all bring us back to skin. Okay. And then let me grab this here, move it. I gotta hold it over here. That's right. Okay, good. So I think we can go on to the next step, right? You want to push that for me? Danny, you want to do that? So we can now, are we ready where we're going to put in the scope now? Is that where we are? Yes?
Yeah, you just want to grab the arm.
Yeah. Right? So we'll take a needle. It's a needle, and we can sort of say, well, I want that portal to be where I'm going to put it. And if I put it here, green, I'm going in the right direction. Okay. Now, if I miss, can you all see how it lights up? I feel a little vibration. I'm hitting the bone because I'm in the wrong place. Or let me just change this again. If I do this, see, and I feel a little vibration. I can see the nerves and everything there. And if I come over here, go more this way, better, kind of better there, right? You follow me? I can't really hear somebody asking me something.
Yeah, looks good.
Okay, so we've got our orientation here for putting the scope in. So once we've done that, I think we can take the scope, right, Danny?
Yep.
And so here we have the scope, and I can follow the same route. We've got and here we can see what I'm going to see here, and I can rotate as I look, and I can raise and lower my hand. You can see here, if I back up, rotate this way, there's the glenoid rim, there's the urinal head. If I come this way, and I also feel vibration if I'm hitting something. I don't want to hit, there's the cuff. Okay, rotate this way. Biceps is coming in there. Okay. And there's a whole bunch of things you can do with this in terms of positioning the scope, etc. And we just move this here a little bit here. Okay. And now we can also go and we can then put this spinal needle in for the anterior portal, right? And we can come here. And as I do this, it's telling me, yeah, there we go. See how nice? So what I found is you see the orientation of my hand here, 90 degrees. You don't even have to look at the camera. 90 degrees between the scope here and this here gets you into the joint exactly where you want to be. So that's, again, an important point in terms of how you do things. So that's kind
So
of.
JP, there's a lot of people that value the lateral position over the beach chair position for Bankar. What's been your experience?
Yeah, that's fair. I mean, it's a little bit like saying golf swing. I mean, if you make par, it doesn't matter, right? But to be fair, whatever you're comfortable with. And I did both of these for my fellows early on, and I just am so comfortable with beach chair, particularly for rotator cuff repair and some of the other things that I do. And for instability, except for Matt Provencher's meta-analysis of lateral decubitus versus beach chair for instability surgery, there's really no evidence one's better than the other. And frankly, if you look, there's an equal opportunity for failure with either way you do it when you consider Bankart repair. And so, but that's a whole nother story. But once I've got this settled here, I think we can go ahead and make a portal, unless other folks have anything else they want me to do. And I can use my probe. I can put the probe in. Oh, that probe not going in there. You have to do something to make it do that. Go in the same direction. I can't hear you guys. What do you want me to do? Do we have to go to the next?
We can hear you. You're doing great.
Do we have to go to the next one? Great. Okay. So we're ready for the probe. Great. Can I take the probe up? I got the probe. Okay, so I can put the probe in like this, and here you can see I'm hitting. I can feel myself hitting something. You'll notice here there's a little blue dot it wants me to go to.
JP, just circling back to that anterior portal, you talked about the posterior portal.
Yeah.
The anterior portal, you know, since you're making it with that spinal needle, what are your internal landmarks that you're looking for? Where are you trying to get that spinal needle to enter the joint?
So I'm coming just under, if you can sort of see here, the portal here, I guess we can use a laser pointer.
Mhm.
How about that? Well, I don't know if you can see that well, but here's the biceps, right? So I'm going to come just underneath the biceps relatively vertically. This is probably the middle gluteal ligament and the subscapularis. And so we're coming down this direction. And so let me put that down. If I put this down, if I rotate the scope and look downward, like at the labrum here, then I want my portal to be able to get down there, and I'm, you know, practicing kind of, okay, where do I want to put my anchors, right? So I also get feedback, and it's hard for me to explain to you. I feel a little vibration if I'm hitting the humeral head. But this shows me that from this particular portal, that will get me to about, I don't know, maybe between 4 and 5 o'clock position. I don't think this module has availability of putting the anterior inferior portal in yet. I don't know if that's correct, Annie, but it'd be very easy to be able to simulate putting the anchor in and et cetera and all of that. But you can kind of see how you can practice where you're getting with the portal and how you look with the scope and et cetera. And in addition, can't remember, we have a 30-degree scope now. Do we have a 70-degree simulation with us? Yeah, we have to, there we go. Here, that's
You have a 70 now.
okay, now I'm 70. So if you see here, you can see, look how low I can see with this now. I'm super low. There's 6 o'clock down below. I can't really get the probe down there. I'm hitting the head. I feel myself hitting the head. Okay. So there are all sorts of things that you can do to practice with where your instruments are going, so that when you finally get to the operating room, you have some sense of where you're putting things and what you're doing. And this is pretty remarkable, this ability, because you're learning to triangulate without actually doing it in a cadaver. And you do get feedback with what you're doing. You can rotate and see things differently with the different instruments that you may use. And so you can see the difference I see with a 70-degree scope compared to a 30-degree scope. Does that help a bit?
Yeah, where do you think new arthroscopists struggle when they're getting going, or when they're trying to practice something more complex like an arthroscopic lateral?
Well, I mean, you know, that's really 3.0 or 4.0 on the level of difficulty. But what you have to learn to do is to use all these portals and view from different angles. Most of us are not using, let's see, how do we go back to 30? Okay, there's 30. So most of us are not using 70-degree, you know, for doing these things. But the point is that you have to understand the inside and the outside of the joint. And so if you're going to do a lateral, you have to be comfortable with opening the rotator interval. And, you know, where my probe is right now, you know, if I back that up and take it up here, the coracoid process is in there. So you have to open up the rotator interval to see the coracoid process. You have to be able to move the scope to see through the rotator interval, which you open. And these are not the usual orientations that you have for doing most of the things that you do. And frankly, I don't think we've gotten to the stage yet where we're trying to teach people those level complexity at this point. I think straightforward rotator cuff repair and instability is probably the extent of it at the moment. But there are other things that we do if you're a specialist, like nerve decompression and things of that nature. If you can imagine it, we can do it. We can simulate the portal replacement, etc. And it's remarkable when you do that and go to the operating room, how it feels so familiar before you actually start doing the real arthroscopy. Okay, that help?
Yeah, great. Thank you.
Definitely.
Definitely.
How are we doing for time, guys?
Great. We got 20 minutes to go.
Okay. Does anybody else want to try to move this? It's just me doing all the talking and everything here. Anybody else want to kind of jump in and show
You've got a
something?
clock on the wall behind you if you need to check it too.
Wait a minute. Wait. Where's my clock? Oh, look at that. That's
Mhm.
cool. But that says 5:40. In what time zone is that? Western, right?
Pacific, yes.
Yeah. Okay. Great.
Jay, what do you find
Yeah.
complex when you're starting shoulder arthroscopy?
I'm sorry. Say that again.
I was going to ask Jay what he finds complex with shoulder arthroscopy as someone who's going to start their
Yeah,
practice in about
no,
6
that's a
months.
good point. I think what Dr. Warner mentioned was interesting regarding looking at things from different perspectives. So we're so used to viewing from standard posterior that once you change to anterior or lateral viewing, it just changes how the feel of the shoulder is and how the anatomy reacts to your movement. So I think that that's one thing that this simulation can help with in particular, even with, I was using this a little bit earlier, when you view from anterior, that's sometimes harder to conceptualize how the instrument's moving when you're viewing from this position. So I'm trying to get a reasonable view of the posterior capsule there. And so using something like a probe, even for something as simple as capsular releases, this can sometimes feel a little bit awkward, you know, just because we're not used to seeing from this angle, especially when I've noticed one viewing TV anteriorly. This is really helpful to have a second viewing monitor. I don't know how many of you used multiple monitors versus one monitor in the OR.
Mainly use it for other people to see. I'm looking at
Yeah.
Well, that's
So
great.
that's
Nice sort of the way you're showing it there. And I think it's also great because the practice posterior labor and repair, this kind of thing, which maybe you don't do as frequently. And looking from that portal, or I don't know if we can do transcuff portal, but we've done that before where you look directly down. It's like the transpatellar portal. But it gives you a bird's eye view, a wonderful bird's eye view of the shoulder.
JP,
Is
when
that
are you
through-
using the transcuff portal? When is your indication for using that?
Who are you asking?
You, JP, if that's okay. When are you
Okay,
using the
yeah,
portal?
sure. I mean, I use a transcuff portal, and what I do is I don't know that we can simulate it here, but what I do is I make an incision through the muscle tendon junction in line with the fibers and sort of switching stick in the sort of cannula. And that gives me a bird's eye view of the entirety of the shoulder, and I can then use instruments from anterior and posterior to very easily. It's like shooting fish in it's like shooting fish in a barrel. You just basically go back and forth, front to back, and posterior Bankart repair with the arm a little bit externally rotated is easier than anterior Bankart repair because of the orientation and the angles. And making a percutaneous portal at the 7 o'clock position is super easy, and you come from much more lateral to do that. And it gives you a perfect angle for placement of anchors down at the 7 o'clock position, this sort of thing. So I can articulate it here, and I think it'd be easy enough I don't know if our module here allows us to do that sort of thing, but to demonstrate it as well. Now, it's different. If you want to do it in a lateral cubitus position, then that's probably a separate module and separate steps because you're used to different orientation and you're used to traction and etc. But remember, we're just doing this in a beach chair position now. So that's my bias in describing this. I actually love doing posterior Bankart repairs in a beach chair position. It's just so easy, particularly with external rotation. The posterior capsule is so lax, you can get to the very bottom very, very simply. And it's much easier than in the front of the shoulder because there's no plexus to worry about. Okay.
And how much are you moving the arms, JP, during rotator cuff repair?
Well, like you showed, Danny, I move the arm quite a bit, and I'll move the arthroscope. Most of the time, my cuff repairs, I'm looking from directly laterally, and I get a great view from that. I use the accessory anterolateral and posterolateral portals like I made here, and simply can rotate the arm to see the different parts of the cuff. And that includes being able to see all the way to the subscapularis and the axillary nerve, if I want, in the front. You can even get to the axillary nerve in the back, viewing from that portal. And so you just simply view that bird's eye view and you can move everything around as you so choose. Typically, if I'm putting anchors in, I'll put them through the either posterior lateral or anterolateral portal. And you can use a variety of different instruments and cannulas or passports or whatever you want. And it's very, very simple to see. I don't usually do cuff repairs even from posteriorly. That's a little bit old school, and I think you don't see particularly delamination and the other things that you really would want to see. And I think all these things can be simulated very nicely to make these points as these modules grow.
So where do you think the issue is? I'm going to turn the skin off here for a second and turn the muscles on. But where do you think the issue is with how people fix rotator cuff repairs? We talk about rotator cuff not healing, but we don't talk about the anatomical reduction of rotator cuffs to allow them to heal. What's your opinion on that?
Are you asking me again or other people?
Yes, I'm asking you, yeah.
So I don't even want to monopolize this, but I can tell you that I made a nice video on ViewMedi that is basically the science and art of cuff release and repair. You want a tension-free repair. And understanding the pattern of tear and how you put it back with the least amount of tension is critical to its healing. And so, when you see type 2 tears or you see cuffs that fail, it may also be a technical error in the over-tensioning of the repair based on the fact that someone doesn't understand. You may want to convert something to an L-shaped tear or do an interval slide in order to reduce the tension in what you're repairing. And oftentimes, you'll have the tendon retracted posteriorly or even anteriorly, and it gets stuck to the coracoid. And Neer described that in his book, and all the steps that we use arthroscopically, Neer did those open. And that's really how we learn to do them arthroscopically. So coracohumeral ligament release, interval slide between the subscapularis and the leading edge of the supraspinatus, or working posteriorly and doing an interval slide between the infraspinatus and the supraspinatus, depending on the configuration of the tear, allow you to bring the tendon back without tension on it before you actually fix it. Okay?
Yeah, that's great. Thank you.
Any other comments from the gang here?
Oh, great demonstration.
All right. Did we cover most of what you want to cover, Danny? Did we leave anything out here?
Oh, it's great. We can go back to Zoom and answer any questions or have a wrap-up conversation. Does that work with you?
Exit the metaverse and come back?
Yep.
Okay, I'm going to just push myself out. I'll see you in a minute. Okie doke.
All right, well, that was fabulous. Great job. I really like the idea that I think Jay made a great point when you're doing things that are, viewing in a different orientation or viewing for posterior. I mean, that's a great way to get up to speed with those, visual spatial kind of psychomotor tasks that are not terribly complicated, but require that kind of hand-eye coordination in a different way than typical. And it's a great way to get reps on that kind of thing very quickly and efficiently. Perfect. Again, I want to remind all the participants, if they have any questions, please just pop them in the chat and we'll happy to answer them.
I just, while people are thinking about their questions, just make a few additional comments. This is actually a wonderful complement to videos you may watch on wherever, YouTube, ViewMedi, whatever, because you can simulate something, watch the video, it resonates more when you're actually in the space doing it, and then you're watching someone do it as well. And frankly, when you do these things and then you go to the operating room to do it the first time, it just becomes much more simple. You've already practiced the steps. It's a little like your practice swing in golf. You feel right, and then you just hit the ball properly. It's more or less the same thing, but you can do it without having to actually be outside or actually in the OR or with a cadaver.
It reminds me a lot of a legendary Duke surgeon, J. Leonard Goldner, used to say your learning curve is the patient's suffering curve, which I think is a fantastic quote. And you could put that up there, JP, in your talk with Halstead. And
I can tell you that, I do think it's true. I'm vice chair for quality and safety, and I have to say, learning curves are not inconsequential. Patients suffer
Absolutely.
from learning curves, and we've seen that. Michael Weider wrote a great paper about his complications with reverse replacement. It took 40 cases before they dropped from double digit to single digit. And so if we can make our errors in the virtual world, not in the real world, just like pilots, we not only will avoid them, but when there's a problem, we'll know how to get out of it. And it's actually remarkable. Think about it. Would you want your pilot to have not done simulation training? Why wouldn't you want your surgeon to be the same? Given that this is exactly paralleling the impact that it already has in other areas outside of surgery.
I think it's fantastic, and that module is just really scratching the surface. I think as we get into and there is a rotator cuff repair module, there are arthroplasty modules that really even expand on this further. This was kind of a baseline anatomic perspective, and it was incredible to hear your thoughts, Dr. Warner, on how you think through portal placement and relevant anatomy. So really excited for the future of this and how we can incorporate this into the curriculum for us as fellows and as residents and even medical students, et cetera.
Yeah, I just want to make a comment because Danny's been relatively silent here, but I think that, this is really for ASES as a pioneer in collaborating here to decide what they want to do in terms of the direction we go, starting from basic and moving from there and building in layers is not only going to improve the skill set for individuals, but it's going to create FOMO for those that are left out, who are going to then request this, that, and the other thing. And you're going to have to decide what are the priorities for what you want to bring in the educational programs that you create to the membership, to individuals that fellows and residents and others, in terms of what they should start with and then how they should grow with that.
Speaking of that, just to segue from that question, Danny, for those that are interested in this, hopefully we've piqued people's interest in this technology. Is there an easy way to get out information about how to download the modules that they might have access to if they go out and purchase a headset?
Yeah, absolutely. They can, I'll put my email in the chat for people who want access to it.
Thanks, Danny.
Yeah, you're welcome.
And Danny, you're gonna have a booth at ASCS to kind of go over your tech and how to get more involved, right?
Yeah, absolutely. We're also going to be running a shoulder arthroscopy competition at the ASCS, and the winner will get a headset and a license. But we're going to collect leaderboard scores, and there's a diagnostic arthroscopy to be done. So we'll be interested to see how people perform in the virtual world.
I can tell you the best way to learn this for those who haven't tried this is just dive in. So if you're able to come to the ASCS, that'll be a fantastic time. We can get everything set up with the Precision OS team and then just try it out. One cool thing is it's so intuitive in many ways in terms of how you move through the space. So I think everyone's gonna have a really good time with this and a lot of learning to be done. Any final parting remarks from our visiting professor, Dr. Warner, or anyone else?
No, I think what we're seeing here is, it was Steve Jobs who said everybody right now feels that the time is right to do something incredible. And we're right there. And I just want to point out, I did a survey of almost 200 surgeons in ASES and CESIC about what they wanted out of digital tools. And as well, the large companies that do this. And we'll publish that soon. But the fascinating thing is the technology that has the greatest ROI in immediacy of return because of lower cost and easier access is VR, not AR and MR, and definitely not AI. And I think that's a blind spot because it's here now. It's just for us ready to use it. It's ready to be scaled. Whereas MR and AR, that's more fuzzy because we're doing it in the operating room and trying to apply it. This really prepares you better for beginning the episode of care, starting with the surgery, and the others don't.
Well said. And we also have a question in the chat. Javier was saying instability cases coming soon. I think that's a great segue. Yeah, there's a lot of modules already built up. The team is continuing to work on new modules. So absolutely. So at the ASCS, you'll see an arthroplasty module. So a different kind of, the anatomy obviously looks different, arthroscopic versus open. And I think be able to it's a nice flex to show the diversity of this to do, different anatomy, different exposures. So absolutely there's quite a robust set of ways you can learn from this type of technology from Precision OS. Perfect. Well, if there's no further questions or comments, I want to thank everybody for kicking it off with us here tonight. I hope to see many of you this coming Thursday at 2 p.m. at our second meeting with Dr. Sanchez Sotelo, and throughout the year as we roll out this curriculum and these courses. So thank you to Precision OS, thank you to the ASCS, and thank you all for joining.
Thank you all.
See you in the
Thank you,
metaverse.
everyone.
And thanks to
Thank you.
JP Warner, Jay Levin, Chris Clipto.
Thanks, everybody.
Thank you, guys.